Hi, my name is Hussein. I'm currently a P4 rotation student at Drake University, a PharmD candidate of 2021, and this presentation is over cardiac rhythms and review. So the basic outline for this is going over measurements, the PQRST, going over rhythms for bradycardias, heart blocks, and then tachycardias. So the first thing that you do is whenever you get a rhythm strip, see what lead you're viewing the patient, because that lead tells you the angle and the direction of you're viewing the heart. And so the thing that we look at first is the P wave. So the P wave indicates atrial depolarization. So the impulse that forms the P wave usually originates in the sinoatrial node. The P wave is going to be upright, smooth, round, and to get very specific, it has to be positive in leads 1, 2, and AVF. Now, on a rhythm strip, you'll notice that there's different measurements that we do when we get calipers for patients, or if the computer does it automatically. So a small box, so a small box here is considered 40 milliseconds, and then one big box that's shaded in gray is 200 milliseconds. So going across here, horizontally, it'd be 200 milliseconds. That's important because when you do these measurements, it falls under a certain criteria for each rhythm. In addition with the P wave, first thing that we measure is a PR interval. So the PR interval is the beginning of atrial depolarization to the beginning of ventricular depolarization. The time it takes for the impulse to travel from the SA node through the atria and the AV node to the bundle branches and ventricles. And if there is a variation in this of the PR interval, then we consider it for other rhythms. So a normal PR interval is 0.12 to 0.2 seconds. If it's less than that, we go into junctional rhythms. And if it's greater than 0.2 seconds, so this should say actually 0.2 seconds, then we would get into first degree heart blocks. And so remember so the PR interval on this example here would be the beginning of the P wave, which is right here, to the beginning of ventricular depolarization. So it would be that segment right there. And we'll talk about these other rhythms later on in this. So for the QRS interval, the biggest thing with these is that we measure the interval itself because that's most important. You'll notice that QRS intervals are very different going from one patient to the next. And so you will get all different types of QRSs and the way they look. And the QRS, you'll measure it from the beginning of the Q wave here to the end of the S wave, which would be right about here, right as it comes back to baseline. Now, if you want to look at estimating the heart rate, what you do is you line up the R on a vertical solid line here. So these solid red lines. And if the rhythm is regular, then you number the next 6 vertical lines, and whatever the next R wave falls under, that would be your rate. So going from here to right here, we do 300, 150, 100, 75, and 60. So this rhythm would be 60 beats per minute. And remember, your QRS is your ventricular depolarization, so the contraction of the ventricular tissues. And really, the biggest thing is that if the QRS's interval is greater than 0.2 seconds, then that's other things that we look for. So the T wave. So the T wave itself is just ventricular repolarization. Usually it'll be in the same direction as your QRS. And again, so if you're looking at a patient, you can tell a lot more than just the rhythm itself whenever you get a strip. So if you have a patient who has hyperkalemia, usually the T waves are going to be peaked and look like tense. And then if they're notched, then it could indicate pericarditis. So you can tell more from a patient just from a strip before you even go and interview them. And then things that we're familiar with, so ST segment. So going from the last slide, you can tell here where you actually measure that from. And then here's also the QT, which we'll talk about next, and then the PR interval. And then also your R to R here. And remember, when we look at R to R's, it's from the first R to the next R. And we should get familiar right now because the R to R interval is going to be important when you're looking at different types of rhythms, and they'll fall under different criterias. So if your R to R is considered regular, that means from this R to this one, and then continuing on, if it's always the same as far as measurements from one to the next, that would be considered regular. So back to this. So if you look at your ST segment here, after the S wave, they call this the J point. So the J point, if it's above, it would be considered ST elevation. If it's below, then it would be considered ST depression. So the major thing and the thing that we worry about most is obviously ST elevation because it could indicate myocardial injury. And after that, we look at the QT interval. So the QT interval is the time needed for ventricular depolarization to repolarization. So it looks at complete and total ventricular activity from the moment it squeezes out the blood to the moment it comes back to relaxing. So full cycle. And a rule of thumb, if you don't have a computer next to you and you want to get a QT, if you measure your first R to your next R and you take half of that, that gives you a baseline of what to look at. If it's less than that, it'd be considered a normal QT. If it's greater than that, then it would be considered a prolonged QT. So in the example here, they've already done it for you, but you measure this one, this R to this R right here. You take half of that measurement, which would be right around here. And since this one in the example is greater than that, it would be prolonged. And the example above is shorter than that, then it would be considered a normal. And so obviously with prolonged QTs, from a pharmacist standpoint, that's where we get into things like torsades. So the one interesting thing is that polymorphic VTAC and torsades, which is also French for torsades de points, is twisting of the points. And polymorphic VTAC and this actually are very similar, and it's harder to differentiate because it doesn't give you exact clues because they could both look the same. So it's actually important for us to know if it's the prolonged QT torsades or if it's actually an MI type of polymorphic VTAC. And so obviously for patients like this, you want to shock them out of it. So if you shock them out of it and you look at their underlying rhythm, you can go forth and to see what treatment plans you want. So for example, if because the treatment plans actually differ between the two. So if you shock this patient, for example, and they have a prolonged QT, well then if you give them something like amiodarone or lidocaine, then you're just gonna prolong that QT even more and just put them back into torsades. But if you have a prolonged QT, the first line treatment is going to be magnesium. So with torsades, the biggest thing is obviously electrolyte imbalances, so hypomag, hypo-K. But if it's the MI form and you shock this patient out of this rhythm and they have a shorter QT, well then you can give the amiodarone, your lidocaine, your procainamide. And so here's just another example. So with this patient, they did have a prolonged QT. And so again, if you shock this patient out of it and got them back into their underlying rhythm and you gave them amiodarone, you're just going to prolong that QT even more and just put the patient back into it. So depending on what type of torsades, so if it's the actual torsades compared to polymorphic VTAC, your treatment plans do differ. That's why it's important to know what the QT type is. And it's important for pharmacists because the prolonged QT is usually going to be medication related. So going into our first type of rhythm, so we're going to go over the bradycardias first. So this would be just our go-to of sinus rhythm. So sinus rhythm, you have a P wave that comes from the SA node. And like we said, it has, if you want to get specifics, for it to be considered sinus rhythm, it has to be upright, P wave in leads 1, 2, 3 and AVF. It gives you the PR interval here. And your R to R is going to be regular. If it's irregular, then it'd be considered sinus arrhythmia. And sinus arrhythmia is actually due to conduction, how the patient is breathing. So if you have an R to R that's regularly irregular, and I'll show you the next example here, the rate will increase as a person is inspiration and will decrease when during expiration. And usually this will just be asymptomatic. It can also be things like stress or if they're on stimulants, etc. And depending on the rate of the patient, then you get into more specifics. So it's less than 60 beats per minute, it'd be sinus brady. It's greater than 100, then it'd be sinus tach. So here's our first example. So there's a P wave here. There's a P wave for every QRS, and the R to R is regular throughout. So this would just be sinus rhythm. And if you wanted to get the rate, so you would line it up here. For example, this is probably the one that lines up the best. So 300, 150, 100. So about 75 beats per minute. So it would just be sinus rhythm. And here's our sinus arrhythmia. So we have our P waves here, right? But the R to R is irregular. So going from this one to this one is very different from the next one over and so on. And so usually these are conduction related and how the patient's breathing. But it could also be other things. Like if they're on, for example, if patients on Adderall or any kind of stimulant drugs or even just caffeine in general. So that was our sinus rhythms. So the SA node is in the atrium. Let's say the SA node does not fire. Then the next pacemaker comes from the AV junction or the AV node. And so with this, what happens is that if the SA node doesn't fire, the AV node fires. And what it does, it sends an impulse down to the ventricles. But at the same time, since they're connected, it can actually send an impulse up to the SA node and to the atrium. And so what happens is that you sometimes do get a P wave, but the PR interval is very small. So it's less than 0.12 seconds. And sometimes it's not even present, and it could be just buried in the QRS. And so it's the same thing as sinus. It's just that the PR interval is non-existent or it's very small. Everything else that we looked at from the sinus rhythm is going to be the same. And then if you have, depending on the rate, you'll also get into more specifics of how to term things. So junctional rhythm, accelerated junctional, and then junctional tach. So same thing here, your R to R is very regular, it's consistent throughout. And in this one, there's no P wave, right? So the underlying baseline is very flat, not much going on here. And the QRSs are going to be small. This one's a little bit wider, but for the most part, your QRSs are going to be much smaller and shorter. And this one looks, this is a good example because a lot of people get this one confused with atrial fibrillation, which we'll go on later, talk about later. So this one, since the rate is higher than 60 beats per minute, it would be considered accelerated junctional. Now, a lot of people would maybe think of this as AFib because they could say, oh, well, you know, this one looks like a P wave here, but lumps and bumps are not P waves. So P waves are P waves. And since the R to R is regular, it can't be atrial fibrillation because AFib can never be regular unless you have a heart block. And we'll discuss that more later on. Since the QRSs are small, there's no P wave, and the baseline's flat for the most part, this one would be a junctional rhythm. And so patients in a junctional rhythm could be due to several factors. So for example, if a patient takes metoprolol and they take more than they're supposed to, it could put them into a junctional rhythm. So it's just looking for underlying factors that could contribute to the rhythm itself. And these are vagal in nature. So even patients who are being symptomatic from this, you could just do atropine, which is just antivagal. And for the most part, is if you want to treat a rhythm, you always treat the ventricular rate. So if this patient here is, if you're wanting to treat the rhythm and their heart rate's, for this patient around the 60s to 70s, then you don't treat it because you always just treat it if they're symptomatic and you treat the ventricular rate. So if it was lower, then you would do something about it. And so SA node doesn't fire, the AV node doesn't fire. So our last line of defense before it goes to cardiac standstill is the ventricles. So the ventricles are the last line to fire, and with these, there's no P wave. The QRS complex is wide, and the R to R is usually regular. So going back to the previous one we just did, it's the same thing as junctional. It's just that your QRSs are going to be wider. And then again, depending on the rates, you get different verbiage. And if you have a regular rhythm that's wide complex, and if the rate is above 130, then that's just your VTAC. So here's a patient here. So again, baseline is flat, the ventricles, the QRS complex is wider, it's regular. It has to be a ventricular rhythm specifically. They call the ventricular rhythms idioventricular. Again, same thing here, regular, they're wide. And so for patients like this, you could do a couple things. You could do transcutaneous pacing. Let's say that doesn't work. You could go on to transvenous pacing. And let's say that doesn't work. Well, then you could go on to doing epinephrine, dopamine. So just depending on which one you want. Now, let's say that doesn't work. There's also incidences of hyperkalemia. So if all those treatments fail, then it could be due to hyper K. And that's in the literature, and it can cause rhythms to look like this. So those were our bradycardias, and now we'll go into heart blocks. Now, the thing with heart blocks, and you can nail every single one down, is if you look at what the PR interval is doing itself. So for example, first degree heart blocks are just greater than 0.12 or 0.2 seconds long, and the rest of them, you'll just look at the PR interval itself. So for a first degree AV block, you're still going to have one P wave for each QRS complex, but the PR interval is just prolonged. So as we said from the very previous part of the presentation, your normal is 0.12 to 0.2 seconds. If it's less than 0.12, then you get into those junctional rhythms. Now, if it's greater than 0.2 seconds, then it gets into a first degree heart block. So same thing as your sinus rhythm, but if your PR interval is greater than 0.2 seconds, you would note it down as sinus rhythm with a first degree block. And from an acute care standpoint, there's really no relevance to this. A lot of patients will have this as their baseline. So younger individuals might have a first degree heart block. And then you grow into a first degree heart block. So a lot of your elderly patients are also going to have the same thing. So it's only going to be relevant if you're bradycardic and you want to treat that bradycardic rhythm itself. And like we said, the treatment is going to be based on the ventricular rate, not depending on what the atrium is doing. So here's one example, and we have a P wave for every QRS. The QRSs are narrow. The R to R interval is regular throughout. The only difference is that the PR interval is longer than 0.2 seconds. So this interpretation would be sinus rhythm with a first degree block. And so if we actually measure the rate, so 300, 150, 175, yeah, about 60 beats per minute. Like I said, so for heart blocks, you always look at what the PR interval is doing. So in a second degree type 1 block, and I'll just call it a Mobitz 1 block from here on out, it's also called a winky back. And so here the PR interval gradually increases, and then you get a drop QRS. So in Mobitz 1, it's actually usually vagal. A lot of people live in a Mobitz 1. So if you're an athlete, you do track, cross country, this rhythm itself is very high in vagal tone. So a lot of people can live in this rhythm, and it has a good prognosis. It's very rarely needs a pacemaker, and since it's high, since you have high vagal tone that contributes to this rhythm, you can always give atropine if the person's bradycardic because it's antivagal medication itself. And so here's our first example. So going from left to right. So we have this PR interval here, and then the next one's here, and you see that it gets a little longer. This one looks longer than that one. And then look, you have a P wave that has no QRS, and then it resets. So you get this PR interval. Same thing here, gets longer, longer, and then a drop. So since the PR interval keeps getting longer and you have a drop, that would be your Mobitz 1 block. Now going into a second degree type 2 block, also known as a Mobitz 2. In this one, again, you look at the PR interval. In a Mobitz 2, your PR interval is always going to be constant. So your Mobitz 1 kept getting longer. In this one, you'll always have a constant PR interval, and you'll have drop QRS complexes. And I did note in here that the P waves are constant. If you measure the P waves from one P wave to the next and march it out throughout the rhythm strip, you'll notice that in all types of heart blocks, they're all going to measure out. And if they don't, then you're going to be dealing with something else. So here's an example here. And so going from left to right, you have this PR interval. And you look at the next one, well, it looks fairly similar. Here it looks identical. And then you have a drop QRS. You have a P wave that's not conducted. And then you go back, and you'll notice here is that there's two P waves here. Now it doesn't matter how many P waves are in there. There could be a million P waves. All you do is you look at the PR interval before the QRS. And so since all of these are the same and you have drop QRSs, then this one has to be a Mobitz 2. And you'll notice with these patients, the QRSs are actually a little bit wider. And in a Mobitz 2 and a third degree heart block, the QRSs are going to be a little wider, specifically in a Mobitz 2 because there's a conduction delay. And so for a patient like this, their future is going to be needing a pacemaker. Now we get into our third degree complete heart block. So if you don't treat a Mobitz 2, the one that we just talked about, it usually progresses into a third degree heart block. And so here you have QRS complexes that are going to be constant. So the R to R is going to be the same. And you're going to have P waves that are going to be constant. The difference is that the PR intervals are completely random. So since they have no association between the P wave and the QRX, then they have to be dissociated. So usually you'll also hear is third degree complete heart block or AV dissociation. So the impulses from the atrium are not being conducted to the ventricles. So they're completely independent of each other. And that's why you'll have PR intervals that are random throughout. And again, you just look at the PR interval and that'll tell you what kind of heart block you're dealing with. And here's an example for this one. So you look at this PR interval and then compare it to the next one, it gets completely longer. And then you look at the next one over, well, then it just goes back to being a short PR. Since they're random, they have no association for each other. They have to be a third degree heart block. And patients like this, the same thing, they're going to need a pacemaker in the future. And again, we're going to go over these one more time. So you have your bradycardias, and then you have your heart blocks. And with the heart blocks, like I said, the PR interval is very important for determining which one you're talking about. So in this example, you have your P wave here. You have a P wave for every QRS. And this one is just extremely long. And since the R to R is regular, it's a shorter one. This one would be a sinus rhythm with a first degree heart block. This PR interval here, if you look at this one next to it, it gets a little longer. This one's longer than that one, and then you get a dropped. This one is actually a P wave. Remember, your T wave is repolarization. So if you have any high frequency wave, that cannot be a part of the T wave itself. And so that is a P wave that's hiding in the T wave. And so this one would be a Mobitz one, since you get the PR intervals getting longer, and then you have a drop, and then it looks like it's going to continue on from there. Again, PR interval, compare this one to the next one over. These all stay constant throughout. And again, you have these P waves here that aren't conducted. And so you have a drop QRS. This one is a Mobitz 2. You got a couple different P waves. So these here and this PR compared to the next one. Okay, it gets a little longer. But then again, it just goes back to just short. And so since it doesn't get progressively longer and it's random throughout, then this one is a third degree heart block. Now getting into tachycardias, there's three things that if you do every single time, you'll get every single tachycardia right. And those three things is looking at the QRS. One, is it narrow or wide? And then the R to R, is it regular or irregular? And then what's the atrium doing? So P waves or F waves. And F waves are going to be related to atrial flutter and comparing that to a normal P wave that actually comes from the atrium itself. So if you have a narrow QRS and the R to R is regular and the heart rate is above 100, then it could be three classifications. So it could be sinus tach. So same thing as sinus rhythm. It's just that heart rate is higher. Could be SVT. So with SVT, you can sometimes see the P waves and other times it's hidden. And with SVT, depending on which criteria you're looking at, usually above 140 or 150 beats per minute. And SVT is an umbrella term. So in the acute care standpoint, unless you want to be an electrophysiologist, you'll actually map out what's actually happening to the patient. So SVT could be numerous things. It could be AV-NRT, could be atrial tach, AV-NRT, junctional tach, and so on. So we put all of those together and we just have one name for it called SVT. And then you could also have atrial flutter with 2-to-1 conduction. And actually, this is one of the most misdiagnosed rhythms because it's of its similar presence to sinus tach, and we'll look over that as well. And usually with this, you will have 2 atrial beats for each QRS, so that atrial beat hides in the T wave, which makes it look like sinus tach. And obviously, you'll have that sawtooth pattern, and that we'll see later on here. So this is a pretty clear example. So you have 1 P wave for every QRS. It's regular throughout. And if we look at the heart rate, so 300, 150, so a little bit over 100 beats per minute. So this would just be your sinus tach. Now, it's very interesting. So the fastest sinus tach you can develop in general is usually going to be age dependent. So if you take 220 minus your age, so if you have a 20-year-old, for example, that gives you your highest heart rate you can have, that's sinus tach. So if you're a 20-year-old, so 200 minus 20, you can potentially have a heart rate of 200 being in sinus tach. And that's very meaningful because if you have an 80-year-old in the hospital, for example, and their heart rate just jumps up into the 180s and they're 80 years old, well, you know that heart rhythm can't be sinus tach. It has to be something else. But obviously, there's also other exceptions, but that's usually the main guideline when you're looking at that. And going next here, so SVT. So like I said, this heart rate is just extremely fast. You really can't tell what's going on, and that's why they put all those terminologies together and call it SVT. So if you're going to be an electrophysiologist or cardiologist, you'll actually map out the pathways that are involved because usually there's a reentry circuit happening that makes the heart rate jump up this high. So again, it's narrow QRS, it's regular throughout. You can't tell if there's any P wave activity going on here or atrial activity, and so you would just classify that as SVT. So now for patients like this, if they were going to the emergency room, then usually you would give them just something that's going to be vaguely like a vagal maneuver. So adenosine, if you give it to the patient, you would just do a adenosine push. And so you could also actually for the very first patient I ever had go into SVT, I was talking on the Vocero with a nurse, and she was completely calm because she was saying that the patient's actually taking a number two. And so if you do number two on the toilet, you're actually stimulating parasympathetic nervous system activity. And so it increases vagal tone. And so this patient literally crapped themselves back out of SVT into sinus rhythm. And so that's all it is. So if you're pushing down and straining, all you're doing is you're increasing that vagal tone. So it's important if you have a patient that's an SVT, administering adenosine or just doing something natural can help the patient get out of this rhythm. And patients who have chronic SVT usually do something like that. So you can blow through a small straw and just push air out, and that stimulates the same exact thing. And so here's your narrow and regular tachycardia with atrial flutter. And you'll notice this is almost similar to sinus tach. If you don't look carefully, you can see that there's other things going on in the T wave. And remember, T waves are repolarization. So if there's a notch in there, it has to be something else. And in this example, it's very hard to discriminate, but if you look into the T waves, it has to be something else going on. So this would be atrial flutter 2-to-1. Again, the most misdiagnosed rhythm. And if you ever have a patient that jumps up into the 140s, 150s range randomly, and it's regular like this, you almost always have to assume it's atrial flutter unless you can find out the actual cause and the actual rhythm. And so for patients like this, uh, you could always look for the first treatment. Obviously, you can cardiovert the patient, and that would be the treatment of choice. And you can also do antiarrhythmics, so you can use procainamide to convert the A flutter. And if your ventricular rate is high, you can use things like, your diltiazem, your verapamil. You could also use digoxin as well, or you could even use a beta blocker. And then, of course, since these patients are at increased risk of a stroke, we want to put these patients on an anticoag to reduce that high risk. Same thing here. This example is more apparent, so you can see the sawtooth pattern going on. And so instead of this one being 2-to-1, it would be more of a 3-to-1 flutter, because you'll have 3 of these F waves for every QRS. And then going into now narrow and irregular. So now instead of looking at regular tachycardias, we're looking at irregular. There could be 3 things as well. So you have your atrial fibrillation, your A flutter with variable conduction, and then multifocal atrial tach. Now, remember, with atrial fibrillation, you can never have a regular AFib, and we'll talk about that on the next slide here. And MAT. So MAT is you have P waves present, like you would in a sinus rhythm, but there's more than 3 different morphologies of the P wave. So you'll get an irregular rhythm, and then your P waves look completely different, at least 3 of them. And that'll put you at multifocal atrial tach. Now, people with MAT usually are going to be your patients with pulmonary issues. So patients with COPD. It's also seen on patients who are taking theophylline, pulmonary hypertension. And so with MAT, you don't treat the rhythm, you treat the underlying cause, because it's the underlying cause that's causing the patient to be in MAT. Again, so here's your atrial fibrillation. The atrial activity is fibrillating, because remember, you have multiple electrical activities going on here and reentry circuits. So the atrium is basically quivering, since there's about 400 impulses happening per minute. And so since those ventricles aren't getting all of those impulses, that's why your rhythm is going to be uncontrolled and irregular. And this is the most common arrhythmia in patients 65 years or older. About 80%, 85% of the atrial fibrillation patients are in patients that are in elderly age. And obviously, main thing with AFib, we want to do rate control, depending on if they're symptomatic or asymptomatic. You can do that with a beta blocker, calcium channel blocker, and then obviously adding anticoag because of the increased stroke risk. And then you need to correct the rhythm itself. So I would prefer electrocardioversion, but you can also use other drugs to get your final result. And so remember, your AFib is never going to be regular, because you can't have a regular rhythm where the electrical activity originates from an irregular site. So since you have so many impulses and it's so irregular, you can't ever have a regular rhythm unless you have a heart block with AFib. And usually you'll see that when your heart rate's low in the 30s. And so here's your atrial flutter with variable conduction. So you have that sawtooth pattern going on, that waviness, and then your QRSs are just going to be irregular with your R to R. And here's your MAT, like I said. So this P wave here is different from this one, which is different from that one. And then this one happens way too soon, and you can't see your P wave. But you'll tell the difference is these P waves are completely different. And since it's irregular and the QRSs are narrow, then it would be your multifocal atrial tach. Remember, this is because of some underlying condition. So it's important to know that your patient's in this, but you won't treat the rhythm itself. And there's actually another thing with this rhythm is that you never shock MAT. because you don't treat the rhythm. So two rhythms that you never shock, two tachy dysarrhythmias that you never shock, MAT and sinus tach. And again, so one example of a patient being an MAT would be like a pulmonary condition. So if they had bacterial pneumonia, we put the patient in MAT. So now we're getting into wide and regular tachycardias. So we just discussed the narrow, regular and irregular. Now we're going to discuss wide QRSs. And really, if you have wide and irregular tachycardia, you should always just go with a go-to, which is just call it VTach. Now, for categorical purposes, you can have a wide and regular tachycardia in sinus tach with aberrant conduction, and then SVT with a bundle branch block. Now, the reason why most people will tell you just to call it VTach is because your treatment options can kill if you do one or the other. If you always treat it as VTach, you can't ever kill your patients. So, that being said, it's very important that if you do think it's SVT with a bundle branch, for example, that you at least have a baseline to compare it to. Otherwise, if you don't, if you just call it VTach, you'll save every single one of your patients. And so in VTach, the P waves are often hidden because you can't have retro P wave activity. And then the ventricular rate has to be greater than 120 beats per minute. Now remember, if it's lower than 120, so 40 to 120, then it would be that idioventricular or accelerated idioventricular. And if it's 20 to 40, then it would be that idioventricular rhythm. And so going on here, so again, wide and regular. So these are two different patients. And you'll notice that these are both are wide, they're regular throughout. And so this would be your VTach. So if the patient doesn't have a pulse and the patient's unstable, so then you'll first cardiovert and then you'll begin drug therapy. So things like amiodarone or lidocaine. Eventually your VTach will develop leads into VFib. Same thing with this one. You'll at least with VFib, what happens is that ventricular fibrillation, similar to atrial fibrillation, so the site is now the ventricles, they are fibrillating. And with this, there's no cardiac output happening. And obviously, cardiovert the patient, and then you can do epinephrine, vasopressin will work as well. And then wide and irregular tachycardias. So if it's irregular, your R to R, and you have a wide QRS, then it can be two things. So your AFib with a bundle branch block, and then your AFib with pre-excitation. Specifically, it gets more complicated. So if you have AFib with pre-excitation, so that's patients who have WPW, Wolff Parkinson's White syndrome, and that gets complicated in its own sense. But for categorical purposes, again, you will have these are the two different rhythms you can have with this criteria. And here's your wide and irregular tachycardia here with AFib with a bundle branch block. Again, your QRSs are wide, but since it's irregular, and it looks like you have some atrial activity going on where it's fibrillating, so this would be your common AFib. So again, to sum it all up and review everything, so depending on what your atrial activity is, so if you have a P wave for each QRS, it gets lumped up into your sinus rhythms. If your PR interval is less than 0.12 and you have a regular R to R throughout, narrow QRS, then it's going to be your junctional. And then going off of that is no P wave activity, no atrial activity, sorry. And then you have wide QRS that's regular, then it gets lumped into that idioventricular category. Now, one thing with idioventricular, you'll see accelerated idioventricular in patients with coronary artery occlusion, and that's where the main rhythm comes involved with. So if you have a patient who has a coronary artery blocked and you give them thrombolytic, so things such as alteplase, what happens is that the patient usually goes into an idioventricular rhythm, specifically accelerated idioventricular rhythm, and that's normal. So people who get those thrombolytics given to them, the reperfusion puts you into that rhythm. Patient usually has no symptoms and is just sitting there with nothing going on, living their life, and they'll go out of that rhythm eventually. And then obviously with heart blocks, remember you just look at the PR interval and what the PR interval is doing. So if it's just longer, then it's a first degree heart block. If it's a Mobitz 1, the PR interval gets longer, 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 and it drops. A Mobitz 2, the PR interval is always going to be the same, and you'll have drop QRSs. And then if they're completely random, then it's a third degree heart block. And then remember, for our tachycardias, ask three things. Is it narrow or wide? Is it regular or irregular? And then what is the atrial activity of the patient? Thank you for your time. I hope you all learned something. If you have any questions, feel free to email me, and I hope to get back to you soon.